as the number of confirmed cases of the COVID-19 virus continues to rise in the United States and frankly around the world, a number of hospitals, clinics, and academic institutions here and elsewhere have started to implement protective measures, primarily to keep vulnerable patients safe during this pandemic. Such measures include now a larger use of telemedicine, postponing elective surgeries, although those now are coming back, rotating providers, less and less so now, and then, of course, maintaining social distancing. With all that, also implementing surge planning to ensure in case that pandemic continue to goes on the track or there's a future surge, that we're ready for the number of patients who may need more intensive care. So we took measures early on. I mean, we knew that we would have to move to telemedicine at some point. At least part of our practice needed telemedicine. So we started implementing that in our digital platform even before COVID-19 spread to the United States. But now we have actually accelerated its use where appropriate. We still see most of our patients actually face-to-face. As you know, most of our patients get treated with chemotherapy and other forms of therapies, target therapies, immune therapies, and so they need to be at the clinic. But yeah, what we're doing is we're prioritizing patients who needs to be into the clinic, who needs to be seen as a video consult, who can be postponed for later on with their scans, etc. So in that, again, we protect the most vulnerable, which we believe are the ones that are on active treatment. So some of the precautions that we've implemented are safety screenings before the patient arrives on campus and again upon arrival. We have requested universal masking for patients and staff and enhanced cleaning above and beyond the CDC guidelines. So not only that we're trying to meet the CDC guidelines, but we're going above and beyond them. The other piece of this is we want to protect our providers, all of them, our nurses, our providers, everyone that works around us as well. Because providers, as providers, we understand that we take risks all the time when treating our patients. However, this is certainly a different level than we have seen. So we want to protect ourselves because ultimately we are the ones who take care of the patients and we don't want to lose providers to illness. On a temporary basis, we've delayed elective procedures, mostly to preserve resources like masks, protective gear, ventilators. This was part of the surge planning. And thankfully, we have been able now to go back into doing these surgeries, but the plan remains in place in case we ever need it again. These measures we have certainly affected our day-to-day operations in many ways, but frankly, we are focusing on safety measures with COVID-19. My biggest concern is that once this is over, and we're starting to see that data emerging from the Netherlands and from other data as well, a lot of patients have delayed their care and have not, or may not for a while, come forth with symptoms that may lead to an early diagnosis of cancer. My concern is that they will present with more advanced disease. Some patients will not come to see a doctor even if they're symptomatic because they're scared to be at the clinic or the hospital. So I'm hoping that the measures that we have taken at Mayo Clinic will reassure our patients for their safety, that their safety is paramount to us. And we hope that their care ended up being uninterrupted. And that's one of the main reasons why we reopened our elective procedures. All our physicians are back fully, all our procedural areas are back fully. So we have to make sure that we care for our patients and the best way we can and keep them safe. We also, have been thinking about some of the intensity of the treatment for some patients and how to sacrifice some of that intensity for their own protection or because of their desire. and we understand that they may affect long-term outcomes. So a lot of discussions, of course, about a balancing act. And as we move more and more towards oral drugs, less patients, frankly, need to be present for an infusion. And so this is important, and we're less likely to bring patients on a routine basis. And we can, again, implement alternative or alternate visits through video versus face-to-face, including symptom checks. And those patients who are potentially cured from the disease, instead of bringing them every 6 months, well, now we'll bring them physically once a year, and then in the midst 3 to 6 months, we'll do a video check. They can get their scans and their blood work independently in our center or even closer to home. So overall, I think we have moved in a direction that has integrated aspects of care that we have always thought should become part of our practice. But I think the pandemic itself accelerated implementing those. In some ways, a tragedy created a good opportunity for us to move into these telemedicine approaches as part of our total care for patients.